This is not a test. Stay calm in an orderly fashion. Make your way to the lifeboats.
Mayday, the ship is sinking.
Welcome back to another ARC presentation. Today we're going to be talking about opioids. Opioids is a class of drug that many have become familiar with because of what we know as the opioid crisis. That's because so many people have been improperly using these painkillers. Basically, we're going to talk today about prescription drug opioids and their impact on older adults. Now, you may think, why older adults? Well, that's an at-risk population. It's not to exclude the fact that there's been an increase in opioid use among Latino and Hispanic populations. And that's a study that came out in 2020, so in the past year. We also know that teens are still very much susceptible to inappropriate opioid use. During the pandemic, opioids have been taking away people's pain, not just physical pain, but a lot of times their emotional pain as well. So let's first talk about what is a prescription opioid. Now, according to RX Drug Facts, opioids are a class of drugs naturally found in the opium poppy plant. Now they are distilled. There can be a lot of different ways that it's distilled, but that's the basic use, where it comes from. Some prescription opioids are made from the plant directly, and others are made by scientists in a lab using the same chemical structure. They go on to say that opioids are often used as medicines because they contain chemicals that relax the body and can relieve pain. And boy, do we have a lot of pain right now. Prescription opioids are used mostly to treat moderate to severe pain, though some opioids can be used to treat coughing and diarrhea as well, right? Opioids can also make people feel very relaxed and high. And that's the thing that people like about it who misuse opioids. They like that ability to be relieved of all pain. For some folks, it's the best they ever feel. Opioids can also make people feel very sedate, can cause them to check out for a while. This can be dangerous because opiates can be highly addictive. We know that overdoses and deaths related to opioid use is really high. Heroin was one of the world's most dangerous opioids and is never used as a medicine in the United States. But we still found ways to use it, misuse it. Hydrocodone or Vicodin, oxycodone, Oxycontin and Percocet, oxymorphone, which is Opana, morphine, codeine, and fentanyl. These are the common prescription medications. Those have been also highly overused by the population. How do people misuse them? I mean, we know that they do, but how do they? They take either medication in a way or a dose that was not prescribed. So if their doctor is prescribing them to take one pill every 8 hours, they might find themselves taking 2 pills every 8 hours, or 1 pill every 4 hours, or just a handful of pills to see how long it will last for the day. Some are also taking the prescriptions of other people. And that's one of the awful things, is that people will get medications and then they'll have them in their house, and somebody will come over and take their medications. And maybe they're using them correctly and the other person isn't. Taking medications for the effect because they want to get high. Now, we have talked very clearly that the use of medications in an addictive manner is not necessarily something that a person has a choice about. Once they start using, it solves a problem. And when they're using, they're solving the problem of pain. And whether that's what we call, actual pain, real pain, where like I smash my finger and I have pain, or if it's long-term pain, bad back or post-surgical pain, or whether it's phonogenic pain where they just can't, there's really no reason for the pain, but it's there. They feel the pain. When misusing prescription opioid, a person can swallow the medicine in its normal form, but sometimes people will crush it or open the capsules and dissolve the powder in water. The problem with this is if you have a long-acting medication where you have one that's supposed to be, it should last you 8 hours because it's slowly releasing itself into your body over 8 hours. And then you take that protective coating off that allows it to slowly dissolve. You're getting all that drug right up front. Now, how do they affect the brain? What are the properties of things going on in the brain that make this an attractive drug? They bind to or connect to, when they talk about binding, here's a receptor and this opioid molecule binds to it. It comes in, and maybe there's like a U channel and this opioid molecule comes, it fits in that U. So it binds to and activates the opioid receptors in the cells located in many areas of the brain. Those cells are all over the place in the brain, the spinal cord, and other organs, but especially those involved in feeling pain and pleasure, which the limbic system. When opioids attach to these receptors, they block the pain signals sent from the brain to the body and release large amounts of dopamine through the body. Wow, isn't that great? When I have pain, what I want to have happen is dopamine to run to that site. If I smash my finger with a hammer, I want dopamine to tell me it's not hurting. I want it to be able to take some of that pain away. And that's why they take the medication. This release can strongly reinforce the fact that taking the drug makes the user feel better instantly, feel better over a very short amount of time, which can perpetuate the continued use. Now, when some possible effects on the body can include drowsiness or confusion, constipation, euphoria, like a feeling like, hey, I'm chill, everything's great with the world. It can also slow your breathing. Think about that. So if I'm drowsy and I'm feeling nothing bad about the world, and I just lay down, chill out, and my breathing slows to a point where it stops, so do I. Opioid misuse can cause slow enough breathing that it can cause a condition called hypoxia. That condition is the result when too little oxygen reaches the brain. Hypoxia can have short and long-term, both physical, psychological, and neurological effects. It can put a person into a coma, cause permanent brain damage, and in worst cases, it can cause death. Now, this is something that we know and we see and we experience when we're working with individuals who have problems with the use of opiates. Now, where is this difference? How do people get off the use of prescription medication and jump over to heroin? I want to touch on that before we start talking specifically about older adults. Prescription opioids and heroin are chemically similar and can produce a similar high. Heroin, though, oftentimes is cheaper and easier to get than the prescription opiates. So if your doctor is prescribing you opiates and you keep getting through your prescription too soon, they cut you off, you might turn to heroin. It's easier to get on the streets. Data from a 2011 study showed that an estimated 4 to 6% of people who misuse prescription opioids eventually will switch to heroin. And about 80% of the people who used heroin first misused prescription opiates. So that we need to be cautious about how we prescribe opiates. We know that that's been a big conversation in the US, big pharma over prescribing opiates. That's the problem, is that if a person is starting to use opiates and they get connected to the opiates and they get addicted to the opiates, and then the doctor says, whoa, yeah, I can't do that, cuts them off, they force the individual into retreating to the streets to get their medications. approximately 1/3 of those who were entering treatment for opioid use disorder reported heroin as the first opioid they regularly used to get high. So only 1/3, which means 2/3 came from a different route. Now, these are all important facts. The other one that we know is another very difficult population to deal with, but we're not going to do too much with that one today, is use of opioid prescriptions when pregnant. An individual, a woman who uses prescription opioids when pregnant, can give that dependence to their baby, and the baby can have withdrawal symptoms at birth. Now, this is a common problem if they get addicted. It's called the neonatal abstinence syndrome, and it's treated with medications so that the baby can titrate off those drugs slowly. Using during pregnancy can also lead to a miscarriage and low birth weight. There's tons of research available for that. It's difficult to quit for a person who's already starting to use opioids, but a pregnant woman who seeks treatment have better outcomes though if they than those who quit abruptly. You know, women will sometimes think like, oh, I don't want to harm my baby, I'm going to stop, and they'll white knuckle it, and then they'll miscarry, and then they'll have that depression and that they've lost their baby, they somehow did this to themselves, and then they reuse. It's a terrible cycle to get into. So now, what's the difference between tolerance, dependence, and addiction on opioids? Well, there is a difference. There isn't, there's I don't want the pendulum to swing the other way. On one hand, we might think that, oh, wow, everybody that uses an opioid is going to get addicted and it's going to be terrible. That's not true. There's a process. They can build up a tolerance for it, basically meaning that what used to solve a problem at one pill is now I need 3 pills to solve the problem. The dependence is I'm starting to have some withdrawal symptoms, and then addiction is just the cycling. Now, long-term use of prescription opioids, even as prescribed by the doctor, even if you're following the rules, can cause some people to develop tolerance. It doesn't mean that if you're just starting to develop a tolerance to the drug that you're given, it's somehow like, oh, you're a bad person. And because we never think about people who get addicted to drugs as bad people. They're not. It can happen. You're going to the doctor's giving you an opiate to, maybe you have cancer, maybe you have, lost a finger, maybe you have a really bad compound fracture, or maybe your back is just out of whack completely, and the doctor appropriately prescribes you an opioid. There's an appropriate reason for you to take that drug, and you're taking that drug as prescribed, and all of a sudden it's not working. That's not an uncommon problem. That means you're developing a tolerance, and you have to talk to your medical professional, because if you start taking a little bit more at a time to try to forestall some of the pain, because don't they always say you got to manage the pain, get ahead of the pain. Well, if you're taking a little bit more because you're getting a tolerance to it, you're managing the pain, but you're starting down this vicious cycle. It's really important when taking opioids that you talk to your medical professional. And that's one of the big things we're going to talk about when we talk about older adults. Now, drug dependence occurs with repeated use, causing these neurons, these little things in our head, to adapt, and they only function normally in the presence of the drug. Isn't that awful? Like if I'm able to, get around a little bit and I take the drug because it's causing a little bit less pain, right? And then I start to develop this tolerance, and now I'm dependent on it because every time I stop taking the drug, I don't feel right. I don't feel good. I start feeling really nauseous, or my stomach's hurting, or something's going on. Some chronic pain patients are dependent on opioids and require medical support to stop taking the drug. Now, drug addiction is a chronic disease, and it's characterized by compulsive or uncontrollable drug seeking. Yet, despite harmful consequences, the person will keep taking. Tolerance, dependence, leading to addiction, you really need to talk to your healthcare professional. So let's switch gears. And before we switch gears, I do want to say that yes, overdose is possible with prescription drugs. But I want to switch gears here and now talk about the older population. Now we know that I'm an older person, right? We know that we are much more susceptible to having problems with pain, chronic medical disorders, like maybe high blood pressure, hypertension, maybe we've got diabetes, we got massive back problems, or we're starting to get arthritis. We're getting old, folks, and we're feeling that getting old in such a way that we go to the doctors. And what does the doctor think? Well, yeah, we can't get into too big of a cycle of creating an exercise program. Well, yeah, you can. But a lot of times we think, I'm just old, give me something to not make me hurt anymore. The problem with that is that there's a much higher risk of overdose with older people because we keep taking the drugs and we have underlying conditions. And with those underlying conditions, it can make us sicker quicker with these drugs. So let's switch gears. Going to take a quick pause, come back, and we'll be talking about older adults. Okay, welcome back. Now we're going to talk about older adults. And I want to bring to you some information that I read through the Florida Weekly on prescription drug usage by Medicare patients when they talk about addiction. Now, older Americans have increasingly become addicted to opioids because it's a wonder drug. If remember before the break, I was talking about all these different conditions that older people have, 65 and older. We're getting older. The body's starting to take some counsel of all of our younger years. Maybe it's our knees, maybe it's our back, maybe it's this, maybe it's that, maybe we're cancer patients. Doctors cannot have those opiates taken out of the cycle of available medications to treat chronic pain in older adults. They're invaluable in directing treatment protocols for individuals who have really suffered. However, there's over 5,000 Medicare patients who suffered an opioid-related overdose every month in 2019 and 2020. 5,000 Medicare patients who suffered opioid overdose every month between 2019 and 2020. That's a lot of older adults, okay? The percentage is 377 percentage points opioid use disorder among Medicare prescription drug beneficiaries. And this grew between 2008 and 2017 to more than 900,000 patients, so that the percentage is 377% of growth between 2008 and 2017 of those individuals who were prescription drug beneficiaries. 25% of Medicare prescription drug beneficiaries are prescribed opioids for pain. These, again, are invaluable drugs, and it's not in any way to say that somehow we should stop that. We have gone overboard. People in our age bracket need these medications, but we need to know the risks. Now, what happens for the Medicare population who's taking these drugs? Well, we see in January, the overdoses. This was all in 2020. January, the Medicare overdoses, 5,011. February, Medicare patients who overdosed, 4,739. March, 4,585. April, 4,170. May, June, July, and August, all up over 5,000. What else was going on during those months in 2020? Let me think. COVID. We see a reduction between January and April, when we had some reduction in numbers, and then when they spiked again, up went, and when there was more people shut down, it spiked again. It doesn't mean that it was bad that we shut down. It doesn't mean that what happened was awful. I don't have an opinion on that. What I'm saying is there was consequences in 2020 for individuals in my age bracket, 65 and older, who had opioid use because of chronic pain conditions or other conditions that were appropriately prescribed to them. 13 million of those in the group who were prescribed opioids are not struggling with addiction. So there's quite a few in the population that don't struggle with addiction. They're not struggling with tolerance and they're not struggling with dependence issues. But still, that doesn't mean that those who are struggling should somehow be set aside. The problem then becomes, what do we do with older adults who become addicted? First and foremost, if you look at the Medicare system, there is not nearly enough treatment facilities for individuals who are on Medicare to go to. I know in our state of Michigan, if I have in mid-Michigan and Lansing area, if I have a Medicare patient who needs to go to inpatient treatment, they're often going to Ohio or way out of county into some other place. Maybe Metro Detroit, maybe Brighton. There's very little resources within the home area for individuals to get, for Medicare patients to get supports. We also know that Medicare individuals who are able to do talk therapy outside of an inpatient treatment program, so once they get done with their inpatient treatment program and then referred out, you have to have a licensed social worker or a psychiatrist, psychologist to be able to work with Medicare population individuals. Many of those of us who work in the industry are licensed professional counselors or have CADCs that are working in substance abuse treatment programs and are not licensed social workers, LMSWs, master's level social workers, or are not licensed psychiatrists and psychologists. So that immediately you have this population that's at high risk, but very few places where they can go to get ongoing treatment, which is a problem. So you have, let's break it down to something simple. You have a person, grandma, all sorts of pain. Grandma has problems. Grandma has been away from everybody during COVID. Grandma has not been moving around as much as grandma should. Grandma has gotten depressed. She's been staying in her home more. She's not going to her doctors as much. She's not immobile as much because she can't, she all kind of ways she can see her doctors through telehealth. So she's not getting up, putting her clothes on, going out the door, going shopping, going and doing this and going and doing that, going to her doctor's appointments, so on and so forth. Get the picture? Grandma is more sedentary. What's the worst thing you can do with a person who has chronic pain? Let them sit around all day. Person who has chronic pain, you want to get them up. You want to get them going, slight movement, doing some exercises, doing some nice kinds of things. And you want them to be engaged. You want them to be engaged in their children's lives. You want to be engaged in the community life. You're following what I'm saying here? During COVID, that didn't happen. So you have Grammy, who's now getting depressed because she can't do anything. She's now feeling worse than she did before. Oh, and let's not forget everybody who put on the COVID pounds, right? And so now I've got grandma who's coming out. She's got her vaccine now. She's thinking she needs to get ready to exercise a little bit more. She's starting to realize, well, maybe I'm taking too many of those pain pills. She talks to her doctor, and her doctor says, yeah, I think we probably should put you into the treatment program to get you titrated off of that medication. And you're living in a place that you need to now go 60, 70, 80, 100 miles away to go get treated. Now, sure, your Medicare will pay for the transport. You don't have to worry about that. You don't have to worry about getting to the treatment program, staying there and getting back. That's not a consideration. They'll pay for that. But forget your family coming on family visit day. Maybe they'll call because they can't come during family visit day because it's not COVID safe. And maybe they can't come all the way to 50, 60, 70, 80, 100 miles away to see grandma. That's a problem. You have taken now an elderly person, and I don't consider myself elderly, but I guess I fall into that category. You take a person who's aging, who has very few things that they've been allowed to continue on doing in their life because of COVID. You've given them a medication that has worked for years in a good way. And now you find that she's taken more of it or he's taken more of it. We got to get her off of it. We got to get him off of it. And now I got to send you away to get it. What's wrong with this picture? Now, Serving Health Insurance Needs of Elders is a program that it's called SHINE that seems to be available. The program provides free Medicare and health insurance counseling and information from an unbiased source. SHINE services are available to Medicare beneficiaries, their families, and caregivers. Oh, through Florida Department of Elder Affairs. Now, the older adult task group that I'm working on with the state of Michigan, with all my colleagues there, I'll tell you, we've done a great job over the last 2 years. And we have a strategic plan now, we have everything, but we don't have the deliverables yet, like many other states where they are addressing the Medicare problem. It's not because we are somehow worse. We just have been slower than some other states in finding the way to manage this care. So now I may seem to be all over the place, but COVID didn't help. Our numbers are up. People are dying. People are having more excessive problems with their conditions because of this. So what do we do with all of this bad news? Well, I know of 3 things that individuals can do that are there and available to you now without too much lift. Within the state of Michigan, we have a chronic pain, chronic health conditions group that utilizes chronic health path and chronic pain path. I'm a facilitator for both of those. Those programs are 6 seminars where it's free. You get a book to use. Now the book, if you want to buy your own books, like $25, not a big lift. If it's a lift, there's ways to get books that you don't have to worry about the cost. And many of these programs now are available virtually. Like I'm coming to you today. I would be online and I would be walking you through the exercises and I would be walking you through the seminars. Those seminars have been proven to be effective in helping to reduce the side effects of chronic conditions. It helps stimulate your thinking, helps you problem solve, it helps you look at new ways of doing things, and it even gives you some guided imagery, and it even gives you in those some mild exercises, things like just bringing your arms up over your head and bringing them down and doing that a couple of times throughout this seminar that's available to you, and it's free. So there is some way that you can help. The other thing that you can help is number 2. So number 1, do a path program. Number 2, talk to one in the state of Michigan. We have Families Against Narcotics. Families Against Narcotics isn't just for young people who are on opioids. This is for everyone who is experiencing problems related to the use of opioids. It brings together professionals and community leaders, as well as those families and individuals who've experienced the problem. There is no age limit. You don't have to be a young person who's become dependent on opiates to come. And those programs, you can look it up, it's FAN, Families Against Narcotics. And there are chapters all over the state of Michigan that can help people. And if you don't live in the state of Michigan, call them anyway, because they would love to be able to start new chapters in other places. But that is a valuable, valuable program for individuals who are aging, as well as for younger people. So that's two. You know, the third one is probably the most important one. Talk to your healthcare provider. Talk to them before it gets out of hand. Deal with your healthcare provider to tell them, listen, I read an article, or I saw a TED Talk, or I saw an ARC presentation like this one. I heard something that says I'm at risk because I'm older and I'm taking pain medications regularly. We need to talk about this, doctor. We need to talk about, yeah, there's been days where I've had to take a little bit more than I thought I should take because it didn't work. Yeah, doctor, I know we switched me from this one drug to that one drug, but you know, it's starting to do the same thing that the first drug did. And guess what? I'm going to be pretty upset if you just say, okay, well, let's cut you off and send you to treatment. What are some other options? What can I do to help my condition besides just taking a drug? You see, those drugs, the older we get, the more profound they act on those neurotransmitters in our brain. Remember the first part of this conversation where I said it sort of binds to, we have a receptor site and that opioid molecule binds to that and allows for all of the extras. So you have sort of like one synapse, right? And it has a lot of dendrites out. There's a lot of feelers out. And that's where you have another part of it that's over here, and both of them go along kind of a channel. So what happens when that molecule bonds over here, instead of it going into the next place on in the transmission, in the neurotransmitter, because that's how they sort of fire off like an electrical circuit, it stays in what's called the synapses, space between the two neurotransmitters. And when it stays in there, that's when it feels like, yeah, that's when I feel great. The problem is, the longer it stays in there, then the less that I'm producing and the more that it's dependent on it. And when we get older, that's more profound and quicker. So we have to talk to our doctor right away. So we say, hey, listen, you know, doc, I heard this lady tell me that I've got, you know, I'm using this drug and it's going to stop making the drug naturally in my body. You know, I want to make some dopamine naturally in my body. What can I do? Oh, maybe a mild exercise program, maybe some stretches, maybe nutrition, maybe eating right, you know. Those, I'm not a nutritionist, but I would probably suggest that you find one or talk to your doctor about referring you to one. You see, the bottom line is the opioid class of drugs is there for pain. It's there to make us feel better when we have pain. And there are some of us that as we age, we're going to need those drugs. They're a valuable piece of our profile. But we know when we cross over and become tolerant of the drug, dependent on the drug, or addicted to the drug, then we're going to have to do something significant, like a treatment program that'll titrate us off, because we don't want to be in that class of people that have overdosed because of it. I hope you've enjoyed our presentation today. If you have any questions, please feel free to contact the ARC and we will try to answer them as best as possible. Have a good day.